Thank you for the invitation to present and also for the introduction. I'm going to talk about nephron sparing surgery for Wilms tumors and the current guidelines that are been established by the SIOP group. So I'd like to talk about general remarks, classification and technical aspects of nephron sparing surgery, and then address to nephron sparing surgery in unilateral Wilms tumors and in bilateral Wilms tumors. These are, for historical reasons, the two giants of Wilms tumor and Wilms tumor surgery. On the left side, you see Max Wilms, German pediatrician, after which this tumor has been named at the end of the 19th century. He named the mixed neoplasms of kidney in children, and he described this, and this has been named after him ever since. And William Ladd is a pediatric surgeon from the US who laid down the ground rules for Wilms tumor surgery, and these are still valid today. Of course, I'm assuming that everybody knows them. I'm not going to too much into detail about this, but this is also something where we started before we were thinking about doing nephron sparing surgery in the kids. So this is the SIOP protocol after which children with Wilms tumors are treated. I'm not going to go through the whole table. I would like to just address the surgical part. And you see that most children undergo surgery after preoperative chemotherapy according to the SIOP protocol. This is not the same for the US-based pediatric surgeons. They have a larger group of children undergoing primary surgery. After SIOP protocol, primary surgery is only foreseen in children below 6 months or 16 years of age because they are outside of the typical age range of Wilms tumors, and in non-Wilms tumors, primary surgery is also foreseen. So children that are treated according to the SIOP protocol have a large amount of chemotherapy that is administered. And allow me to just very briefly address the histological background. As I said, it's a mixed tumor with three different components, as you all know. And this is something that is important because after chemotherapy, we know that there are changes in histology and in its histological components. And this is extremely important for the plastimal type. And you see here in yellow, the histological subtypes when children are resected without prior chemotherapy, and in red you see the histological subtypes where children underwent have primary surgery in red and primary chemotherapy in yellow. And you see one of the most important differences is the blastemal predominant subtypes, and according to the SIOP protocol, children with blastemal predominant subtype are considered as high-risk patients. Again, that is something for us as surgeons which is very important. There has been introduced a new classification of nephron sparing surgery, and this is because there have been many different types of surgery that have been described for nephron sparing surgery. For example, some authors do heminephrectomies, partial nephrectomies, enucleations, wedge resections. Sometimes they do the same but describe it differently. Sometimes they do different things. So the SIOP renal tumor study group came up with this new classification which allows to put all the different types of nephron sparing surgery together. And this new classification considers four aspects. The first is the surgical technique, and there's the question whether or not you have a rim of normal renal parenchyma around the tumor that you resect. If so, it is a nephron sparing surgery type A. If it's not rim of renal parenchyma, it's a nephron sparing surgery type B. So this is differentiating between the two types. Second point is the surgical resection margin. The surgeon is asked to judge whether he has either an intact pseudocapsule of the tumor, whether he's in doubt, or whether he's certain that he has a tumor breach. And this goes down to the same classification then. Third aspect is the pathological resection margin. The pathologist is exactly asked the same question. Is there a safe rim of tumor? Is there an intact pseudocapsule, or is there tumor breach? And he also has his information to give in this classification. And the fourth point regards the remaining renal parenchyma in percentages as judged by the surgeon. So these 4 points add up to this formula, which is then given to every single case, to every single kidney. And here I have an example for this from our own hospital. And this is now a nephron sparing surgery type A with same safe rim Surgical resection margin 0, because the surgeon was certain that there is intact tumor capsula and an intact rim of parenchyma. Pathological resection margin 0, the pathologist saw an intact capsula, and the remaining percentage is 70. So this is something that everybody should have in mind and should add to his information, because that makes the different types of resections comparable. Challenges of nephron sparing surgery, no matter whether unilateral or bilateral, are polar versus central tumor localization, the tumor detection during operation. This can be sometimes very hard. Infiltration of the renal pelvis, need for R0 resection, amount of remaining tissue, single versus staged approach in bilateral tumors, surgery with or without total vascular exclusion, and the management of urinary leakages. So recommendations, and this is something that we do in Tübingen. We do an exploration of the kidneys and judge the extension macroscopically. We always do intraoperative contrast-enhanced ultrasound. And this is extremely important to be able to detect and judge the borders of the tumor. We do extended dissection of the renal vessel down to the subsegments, because this shows us whether we can preserve some of the vessels or whether we have to take them. And then we do a single stage approach in bilateral tumors. We always do clamping of the vessels and hypothermia with application of ice water. We perform selective hemostasis with atraumatic sutures. We do intraoperative biopsies from the renal remnants to be able to judge R0, and we do reconstruction of the pelvis and drainage of the pylon if there's a big opening. So this is some examples from our clinic. Here you see a bilateral case where we perform this bloodless tumor resection, which is possible because of the vascular exclusion. And sometimes this is a millimeter question, and there you need to be certain where you are. And it is very, very helpful if you don't have blood running through your operation field the whole time. Another example where I wanted to show you how meticulously we prepare and dissect the vessels down to the subsegment area, and through this we are able to take vessels away selectively if they are providing the tumor, and we are able to identify those that are going to the renal parenchyma. Sometimes the kidneys look very, very sad, but they are functioning and they are recovering quite well. This is an example here where we opened the renal calyces and we do the suturing. For clamping, we always use atraumatic instruments because you have the risk of intravascular dissection. And this was a case where we needed to patch the renal artery because we had such a problem. So we do either use small bulldogs or Yasaki clamps. And as I mentioned, we always perform contrast-enhanced ultrasound during operation because in this case, for example, there's tumor here which can be seen on ultrasound. There's tumor here which can be seen on ultrasound. This is not tumor, and this shows you where the parenchyma is and where the tumor is. And this is, as I mentioned, very, very helpful and necessary. So let me turn to nephron sparing surgery in unilateral Wilms tumors. We need to understand that unilateral Wilms tumors and bilateral Wilms tumors are very, very different when it comes to nephron sparing surgery. In unilateral Wilms tumors, this is a technique which is only applicable in selected cases. In bilateral tumors, it's the technique of choice. And again, I'm coming back to histology because you can see here in this case where we have a very, very good depiction of the border between tumor and healthy parenchyma. And this is the key for us, which we need to know because we need to respect this border. And in cases of unilateral Wilms tumors, we even have to have a safe rim of parenchyma to go with it. What is the rationale to do nephron sparing surgery in unilateral Wilms tumors? For decades, we have been hearing that it's not a problem to take one kidney away because the other kidney will take over the work and the kid will be fine. But some data are out there that seem to indicate that these paradigms are changing a little bit. And as example, I put up this table from the group of Kotzi et al., who published a lot of data about this. And this shows you the comparison of renal function between groups. Group A are kids undergoing nephron sparing surgery within 2 decades. Group B is the same operation, but total nephrectomy in the first and second decade after surgery. And group C is kids undergoing total nephrectomy in the 3rd, fourth, and fifth decade after surgery. And you see here that in group A, there's a significant increase of renal function in the first 2 decades. So if children undergo nephron sparing surgery, the authors observed this significant increase. In group B, there was no significant difference. So children 2 decades after surgery, when there was total nephrectomy, have virtually the same renal function. But what the authors observed was that from the 3rd to the 5th decade, there was a significant decline in renal function when children had total nephrectomy. And also what they observed was that there's a difference between whether children have taken away one healthy kidney, healthy in parentheses, or when there's a kidney that is afunctional from the beginning on. So this is a problem that we need to know, and that is also something that is a rationale for nephron sparing surgery in unilateral. The SIOP renal tumor study group put up these criteria for nephron sparing surgery in unilateral Wilms tumors. And it is the first time that a protocol has now criteria which can be followed. So tumor restricted to one pole of the kidney or peripheral at mid-kidney. The tumor volume should be below 300 milliliters at diagnosis. And this is because if the tumors are bigger, then there is a large risk of positive lymph nodes in that area. Positive lymph nodes means that there needs to be post-operative irradiation. And if we perform post-operative irradiation on the operated kidney, this can then again lead to renal function problems. No preoperative tumor rupture, no tumor involvement of the renal pelvis, no invasion of the surrounding organs, no vascular thrombosis, unifocal tumors, and excisions are possible with safety rim margins. Protection of 2/3 of the renal tissue is possible. So those are the criteria. If children are meeting these criteria, they are candidates for nephron sparing surgery in unilateral tumors. And the SIOP group, for the first time in a larger cohort, analyzed this technique against the group of total nephrectomy, and this published in 2014 showed that the nephron sparing surgery group has significantly smaller tumors at diagnosis and pre-operative compared to the total nephrectomy group. However, there was in this cohort were 12 patients with stage 3, and that is important because stage 3, as I mentioned, are those cases that have to undergo irradiation, and this shows what happened to those kids. And 3 of them had radiotherapy, 1 had subsequent total nephrectomy and radiotherapy, 1 had subsequent total nephrectomy. And this is something that we need to be sure of and which we have to further evaluate in further studies. When we look at survival, we see that there's no difference between nephron sparing surgery and total nephrectomy in this study. And this is something that has been verified by various authors meanwhile. So it seems to be safe from an oncological point. We need to know that these are sometimes particular operations which should be done by somebody who has experience. However, what we see here is the numbers are very, very different. So in this study, the rate of children undergoing nephron sparing surgery for unilateral Wilms tumors was below 5%. And from big centers, we would think that the rate of candidates, if we look at the criteria that I just showed you, is something between probably 15 and 25% of children. So let me finish now with nephron sparing surgery in bilateral Wilms tumors. There are challenges of this technique in these cases, and this is metachronous tumor development. So we have the fact that in some kids we have a tumor on one side, especially in cases where we have a genetical background, and then this is possible that to a later point there appears tumor on the other side. So in these cases, we also see these children as metachronous bilateral, and we do nephron sparing surgery in them. Tumor in the renal hilus, multifocal nephroblastoma, tumor thrombus in major vessels, and unfavorable histology are also problems that are, or challenges that are seen in this group. This is the treatment of children, and we see that from diagnosis, children receive 6 weeks of chemotherapy, and then they receive surgery. If we do in bilateral cases both sides in once, then the child is finished surgically. If there is a stage approach where we do first one side, later the other side, then the children receive another block of chemotherapy. We have to be aware that anaplastic and stromal predominant tumors are the possible non-responders. And this is, for us as surgeons, very important, because anaplastic tumors would benefit from an increased amount of chemotherapy, possibly, whereas in stromal predominant tumors, chemotherapy will not do very much. So this is something we need to know when a tumor does not respond. Sometimes it's difficult to determine. Over time, we came away from this concept of bilateral nephrectomy and dialysis because the overall survival is very, very poor compared to bilateral nephron spraying surgery. So today, the concept of bilateral nephron spraying surgery is the concept of choice in these children. However, we need to be aware that also in this group, 12% of children develop renal insufficiency after surgery. This is an example from our clinic where we have a stromal predominant bilateral Wilms tumor. Tumor did not respond to chemotherapy. And these are images from the right side where we did a polar resection with reconstruction of parenchyma and pelvis, and the kidney was well. We did this in a single stage approach, and the other side we were able to also do the nephron spraying procedures and save the child with good functioning kidneys. And for the complex cases where we have involvement of the renal hilus, we established the technique of longitudinal partial nephrectomy. And in these cases, we open the kidney up, and you can see here that we are longitudinally dissecting the tumors away from the vessels in the hilus. This is also something that I've shown you before. The dissection of the vessels is extremely important. And we go down to the renal pelvis and dissect the tumor away, where we are able then to dissect the middle part of the kidney. And in this case, we had good recovering with normal renal function and no evidence of disease afterwards. And we evaluated our technique in a study that we did some years ago. By now, we have experience with almost 50 cases, and we saw that in these cases of procedures, we had reasonable operating time, clamping time of about 20 minutes per case. We didn't have any problems with renal function after clamping, even in one case where we did the clamping for as much as 45 minutes. Complications in these 16 cases were seen in 5 patients with urinary leakage and 2 cases of vascular occlusions, and outcome was with overall survival of 1 in 16, with 1 with anaplastic, relapses in 2, and none of the patients had end-stage renal failure. So I would like to conclude that we have a new nephron spraying surgery classification, which should be used by the treating centers. Nephron spraying surgery is indicated in selected unilateral Wilms tumors, and we need to be able to have the criteria ready. Nephron spraying surgery is the treatment of choice in bilateral Wilms tumors. The goal is to preserve as much healthy renal parenchyma as possible. The single-stage approach in bilateral Wilms is safe, and longitudinal partial nephrectomy can avoid tumor nephrectomy in central Wilms tumors. We have good functional long-term outcome and analog outcomes compared to other Wilms tumors. Thank you for your attention.